that would require intensive care. And then most recently, I've spent several years with the University of Colorado Health Sciences Center in the heart failure clinic, dealing with clients, a lot of young people that had heart failure that were on the heart transplant list, and we bridged them to transplant with investigational drug studies. So this is a topic, both of these topics are near and dear to my heart, and I do have experience in those, and we'll give you some interesting case studies that hopefully will stimulate your thinking and maybe change how you view these diseases. I do have a handout that I have here that I've asked Phil perhaps if he can post with that link, so that has a little more detail than the PowerPoint does, so that you don't have to jot notes furiously. So the first topic we're talking about is COPD. That stands for chronic obstructive pulmonary disease. And that is one of the most common lung diseases in the U.S. right this second. What that means is the leading cause of COPD is usually past or present smoking. So we have a lot of those in our society, and so we see a lot of these kinds of clients. It is a progressive disease, which means that it gets worse over time. What COPD is it's basically less airflow in and out of the lungs with each breath. There's two main diseases in this category of illnesses that we see, and that's emphysema and chronic bronchitis. They each have a little different etiology with the same result. Emphysema is where the airways and the air sacs, which are called alveoli, they lose their elasticity. Picture a small balloon and how when you blow air in it, it expands, and when you let the air out, it condenses. With emphysema, those air sacs do not move. They lose their elasticity. With chronic bronchitis, the airways are narrowed from inflammation and excessive mucus production. And you can see on the little picture there's the two mechanisms, but again, they have the same result. A lot of people with COPD actually will have both. So understanding the etiology is important, but just know that a lot of people will have both. The normal symptoms of COPD are a productive or an ongoing cough. Sometimes it's a dry cough, sometimes it is productive. The key with the productive cough is if it's colored sputum, and everybody hates to look at this, but if if they're coughing up into a tissue, ask them if you can look at it or ask them what color it is. My family's kind of funny because they always, whenever they have a cough and they're spitting something out, I say, what color is it? And they're like, ew, I don't want to look at that. But it is important to know what color it is, because if it's green or yellow, it could be they have pneumonia on top of that, and so you need to know that. Another symptom is shortness of breath, especially with exertion, wheezing, and chest tightness when breathing. So the biggest thing I wanted to talk about with these is that these clients breathe a little bit differently than you or I or somebody without lung disease. The normal respiration in somebody without lung disease is what causes us to breathe, which is called the drive to breathe, is the level of carbon dioxide in our bloodstream. Carbon dioxide gets dissolved and floats around, and we have these little chemoreceptors which send signals to our brain to either increase our respirations or decrease them based on this CO2 level. With somebody with COPD, their drive to breathe is different. And what frankly caused me to talk to Phil about this, I said, we need an education piece with this, is there's a whole slew of people in society, both medical personnel, physicians, that are not teaching people with these diseases about this. And I'll give you a case study about this at the end. But the respiration and the drive to breathe for a COPDer is actually hypoxemia, or a low level of oxygen. They chronically run around with a high CO2 level in their bloodstream because with each breath, they're not able to get rid of all the carbon dioxide. So that is not what causes them to take their next breath, like you or I. It's the level of oxygen. So the biggest danger with these clients is if we give them too much oxygen, they can actually slow down their breathing or stop breathing. Now, I want to qualify that because obviously, for somebody who's hypoxic or low on oxygen, we want to give them oxygen at the highest flow we can. If they're in a situation where you're getting ready to call 911 because they're not breathing very well. So you can't withhold oxygen based upon that, but I think it helps to understand this and understand the drive to breathe and how it's different for a COPDer. Many of you probably already know about a person who is hyperventilating, and how do you treat that? Hyperventilating means they're breathing too fast. Anxiety can cause it, any number of things. And what do? You give them a paper sack and they breathe into that paper sack because to bring in some more of that carbon dioxide, because when you're breathing so fast, you're blowing too much carbon dioxide out. So it kind of makes sense that if you're breathing too fast, you're getting rid of too much. If you're breathing too slow, you're holding on to too much. So it's kind of how our body works. So as I said, the first priority is always to treat the hypoxia if they have a low oxygen level. One of the things I wanted to share with you is some of the normal oxygen levels. A lot of our clients have what's called a pulse oximeter, and that measures the oxygen saturation in your bloodstream. It's not as accurate as an arterial blood gas, where they actually stick the client in an artery, draw out blood, and they can measure all the different things, but there is a correlation between the level of oxygen in the bloodstream and that pulse oximeter. So a client that did that, and I've actually talked to Cheryl about this, that it would be nice to actually show you how to use those. They're usually easy. It's a push button on. You stick it on their finger. It measures the pulse. It measures the oxygen level. A normal oxygen saturation for a person without lung disease is 95 to 100%. The normal for elderly people without lung disease, just naturally because they're not breathing as deep and their lungs aren't as efficient, is 93 to 96%. A normal for a COPD or somebody who has pneumonia is 90 to 92% for their oxygen saturation or their pulse oximeter. So if you have a client whose pulse oximeter is 90 or less, they are in imminent need of either increasing that oxygen, calling 911, calling the doctor, and that's really based upon their symptoms. You're the one in the home, you're the one seeing the big picture of what they're looking like, and we're going to talk about that, is what some of these symptoms of hypoxia or low oxygen look like. And those are, so these are the symptoms of low oxygen and when you should call the doctor or even 911. If they're having a hard time catching their breath or speaking. Number 2, if their lips or fingernails are blue or gray, that means they're not getting enough oxygen. And usually the first sign of hypoxia is a client is not mentally alert or they're confused. If you don't have access to a pulse oximeter, you can go by these symptoms. If they're seeming confused and they're not looking too good and they say they're having a hard time breathing, you need to get 911 on the phone. That means that they've had what's called an exacerbation of COPD, which means it's worse. It's a progressive disease, as I told you at the beginning, and they do have times when it just gets worse and they have to be hospitalized and given IV medicines to bring them back, hopefully, to the level where they were. So the other thing is if they're low on oxygen, their heartbeat or pulse is going to be very fast. Or if they have an inhaler that they're supposed to use, PRN, as needed if they're short of breath. So if that's not working, or they have a PRN nebulizer treatment and that's not working, they still feel short of breath and feel miserable, and any one of these symptoms, based upon how they're looking, can affect how you treat that. Any questions so far? I'll watch for questions as we go here. So normally these clients are on low-level oxygen, usually by nasal cannula. And one of the things with a nasal cannula is really it shouldn't be more than 5 to 6 liters per nasal cannula. And we have we have oximeter, so it's a pulse oximeter. I'll type it for you. We had a question that what is a pulse oximeter? So it's like oximeter. And let's see. Oh, nasal cannula. So one of the things we'll find, and I found with some of the clients I've actually seen, is they feel short of breath and they crank up their oxygen. And really, one of the things, when I see a COPD on a high level of oxygen, I've actually called the doctor and said, do you realize how much oxygen this person is on? Because normally 2 to 3 liters is really what they're at, and sometimes they can go up to 4 on exertion, that sort of thing. But just let it be a red flag for you that if you see somebody on a high level of oxygen and they have COPD, that we need to make sure that the physician knows what that we know what the physician knows what level of oxygen they're on. So the normal saturation, we're getting a question about the normal saturation for somebody with COPD is 90 to 92%. So it's on the lower end. It's when it gets below 90, that's our big concern. But the only way we can check that is if we have a pulse oximeter in the home, and not everybody does. They're not that expensive. They're $40 to $60. And, if Christy posts, the other nurse on the other side, or me, if we see a client, I usually suggest that we can apply to Medicaid to get one, or maybe the family, if they have the means to go get one. It's a great tool to be able to really know what's going on with these clients. All right, the other thing I wanted to talk to you about is if they get too much oxygen. There's a symptom of too much oxygen, and that is drowsiness and difficulty staying awake. And the only way to really accurately assess that is with the arterial blood gases. But you might see if somebody's really sleepy and having a hard time staying awake, if you can check their pulse oximeter, it could be low. But too much oxygen sends a message to the brain to slow their breathing, so it actually makes it worse. So it's really a delicate balance with these clients. So the other thing, let's see here, I'm not changing my screen, sorry. I'm just too busy talking. So I just gave you the values. And we're talking about some of the symptoms. So one of the things with severe COPD, this can cause other symptoms as well, such as swelling in their ankles, their feet, or their legs, weight loss, and that primarily is because they have a hard time eating. A lot of these clients I get so short of breath eating, talking. So one of the recommendations is to actually have them rest before they eat a meal so that they can get adequate nutrition. Because as you know, without adequate nutrition, it kind of compounds it, then their body can't work on the oxygenation and all those things. So nutrition is very important with these clients. And you might have to plan for it. It might be their big event of the day, their noon meal. It takes them, 2 hours to eat it because they eat slow in small amounts. And, the other thing is to break up that big meal into several small meals to make it more manageable for them. Another symptom of severe COPD is decreased muscle endurance. And they also have, because of the chronic inflammation, it actually makes their blood clot more easily, and they're at high risk of blood clots. So I know we had a client down in South that all of a sudden had a stroke, and there were no indicators that this was coming. Now, she's somewhat sedentary, and that can make you throw a blood clot, but it also is just a nature of this illness that it makes your blood more clot more easily, and so you're at risk of a blood clot, which would lead to a heart attack, a stroke, a pulmonary embolism, or a deep vein thrombosis. If you have any questions on the signs and symptoms of those, we could maybe go over that at a later date. So I told you some of the treatments about resting before eating, some physical activity. Some physical activity will actually help them because it'll increase their muscle strength, and it'll also strengthen those breathing muscles. So even though they might not feel like it, if you just take a short 5-minute walk around their home, every little bit helps, and just pace them. The key is not pushing them too hard and just pacing them. And the other thing is if they're still smoking and yet they're trying to quit, to just help them, reinforce and encourage them to help facilitate if they really want to try to quit smoking. Obviously, we're not the dictators. We can't tell them what to do. We can suggest and we can encourage. So, and that's certainly one of our roles as caregivers. So, what caregiver-initiated things can we do to help relieve these symptoms? If you have a pulse oximeter and you can check the oxygen level and kind of determine whether that's a temporary thing or they're getting worse and need medical treatment, that's a great thing. If they don't have that, you check those symptoms of hypoxia that I gave you. And you need to increase their oxygen and call 911. If they're hypoxic, if you have any change in level of consciousness or confusion, you need to increase the oxygen because it'll only get worse and they get the medical treatment they need. So if their oxygen is stable or they don't have that first indicator, the confusion, sometimes it helps for them to sit up. Some clients, you'd think they'd know this, but some of them don't. They'll be lying in bed saying, oh, I feel so terrible today, I can't breathe. Well, get them in an upright position. The other position that helps COPDers is bending forward, kind of a tripod position, bending forward with their elbows or their hands on their knees. That can sometimes help their breathing. And if they have orders for a PRN nebulizer or inhaler, to try that. The key is to follow it as ordered. Just a quick story, I had a student who was an asthma patient, and they thought that, when they were short of breath, that, 2 puffs is good and 6 puffs is better. Well, if you do that, it's really like 2 puffs every 4 to 6 hours usually. If you do that too many, you can make your heart rate too fast and make things worse. So just make sure you follow the directions. We have a question, do the change in positions relieve pressure? It's more that they help the diaphragm expand and help them breathe a little better. A lot of these clients have, you'll notice, a barrel chest, which means it's more like a circle. It's not just a normal elongated chest like you or I. And that's just because it's difficult to breathe, difficult to get those sacs to let all that CO2 out, and so sitting up. We have another question, would a cool mist humidifier help? It might. Sometimes these clients on oxygen have a humidifier on their oxygen. It's unlike some of the respiratory illnesses where we use a humidifier like with a cough, but we do live in a dry climate, so it won't hurt anything. So yes, it's a good thing to try, cool mist or even the warm mist vaporizer.
Cheri, is there any concern for people possibly getting pneumonia? I mean, when you have that humidity or any of that in the air, is there any additional risk for pneumonia or additional bronchitis or anything like that?
There aren't a whole lot of studies on that. They usually say it helps, but it's going to be individualistic. If you help a client set up a humidifier and they're coughing more, you kind of have to use your head. If they're coughing more or their cough becomes productive, and again, it's that colored sputum, then lay off the humidifier and they probably need to see a doctor. So, it can't really cause pneumonia, like be a breeding ground, yeah, but you have to watch them closely.
Okay.
All right, so we talked about when to call the doctor. We talked about things that we can do. One of the things I just wanted to briefly touch on is the common medications. We talked about, inhalers and nebulizers. What they usually are putting in those are bronchodilators, which means it helps open up those airways to help them breathe easier. Sometimes they're on a inhaler that's a steroid that decreases that inflammatory response and helps them too. And when they have an exacerbation of COPD and they have to go to the hospital and be admitted, it's usually to get IV steroids to help this episode, help them feel better. One of the things I want to talk about is the emotional response to COPD. They have a high incidence of clinical depression. And it's not only because psychological from their restricted lifestyle because they have a hard time breathing, it's also biochemical from the metabolic and inflammatory changes that COPD cause. And they also have anxiety because they can't catch their breath. Think about how you feel when you jump in the swimming pool and you're down at the bottom and you're kicking your way to the top and you have to hold your breath. And they kind of feel like that all the time because they're like half holding their breath because they can't expel everything. Case study. This is what drove this whole discussion, why I volunteered to do this with Phil. We have a client in South that had no idea about how the oxygen and how a COPD client, what causes them to breathe. And I spent about an hour teaching about it. She said her doctor, the nurses, nobody had ever told her about this because what she would do, she'd be on like 3 liters nasal cannula of oxygen at all times. And then when she got in the shower, it was so exhausting, she would up it to 5 or 6, but she would feel worse. And so I explained to her that actually that was probably too much oxygen for her, and because of what her drive to breathe was low oxygen, and so by increasing that oxygen delivery, she was actually making herself slow down her breathing and feel worse. So again, based upon the symptoms, you'll now have the information to maybe understand that we have to kind of just monitor that and help our clients understand how it works, how their lungs are different, what causes them to take that next breath is different. So we're going to switch to CHF. That stands for congestive heart failure. It's also called right-sided heart failure. And basically, that reason for that is the effect on the heart. A lot of these clients, will use the term heart failure kind of generally, but they usually have an enlarged or inefficient heart in the ventricles, which is the lower part of the heart. That's the pump. And multiple factors can cause that. I've seen clients and patients that have had a viral illness that causes their heart to become enlarged or damaged, or post-heart attack. Any number of things can be the causative factor. But the result is that the ventricle isn't pumping effectively. And so therefore, the blood backs up into the lungs or into the systemic system, and they'll have edema and swelling or weight gain and things like that. So the biggest thing with congestive heart failure, the single most important way, very easy to do, to see how a CHF client is doing is to have them check their daily weight. Most people have a scale. If they don't, encourage them to get one, and then to write it down every day. Sometimes you can see a weight gain of 3 to 5, 8 pounds in one day. Guess what that means? That means that their heart, the fluids are backing up, they're retaining fluid, and they need to let their doctor know. And usually they increase the diuretics or they adjust their cardiac medicines. So that's the single best way to monitor CHF, is by taking their daily weight and recording it, so that you can see a pattern, that they can see a pattern. They can go into their doctor and bring it and see a pattern and see if the medications are working the way they're supposed to. I wanted to give you some of the normal, the other way to check these clients is to check their vital signs. And I wanted to give you some of the normal vital signs, because sometimes we don't always have access to that. So a normal blood pressure is 100 to 140 over 60 to 90. A normal pulse is 60 to 100. A normal respiratory rate is 12 to 20. So one of the things with CHF clients they might have normally a low blood pressure, or even a pulse, because a lot of the medications they're on lower the blood pressure and lower the pulse. You'd think that lowering the pulse would not be a good thing, but like one of the beta blockers, metoprolol, it lowers the pulse, but it makes it more efficient. With each heartbeat, that heart is pumping stronger and more efficiently, and so it's actually better for the client. One of the things that's very important, sometimes the cardiologist will change around the medications, and since they do have such a direct impact on the vital signs, on the pulse and blood pressure, when I go into the home for PeopleCare and I do my intakes, I always ask if they have a blood pressure cuff, and if they don't, I encourage them to get one. They can get one at Walmart for $10 or $20, and it's well worth it to be able to monitor that daily, because that can change. And if the doctors change the medicines, you want to check and see what their pulse and blood pressure is before you, especially if we're the ones administering these meds. It's a great idea to know what you're dealing with. Some of these medicines need to be held if the pulse is less than 60, or the blood pressure, the top value, the systolic, is less than 90. So it helps for you to know what those are. So, and sometimes the physician's orders will say that, sometimes they won't. So it's just good prudence to know what your vital signs are before you're administering some of these cardiac meds. I told you about the beta blockers. The other crucial medicine is sometimes these clients are usually on a first-line medicine called an ACE inhibitor. One of the most common ones is lisinopril or any of the prils. And the other thing that they're on are diuretics, usually Lasix. It's important for you to know that Lasix is a potassium wasting medicine. So most of these clients are on a potassium supplement unless they have chronic or acute renal failure. Then the doctors usually won't put them on that. But if they have a low potassium level, that can make the heart do arrhythmias and have funny beats and be life-threatening too. So just know that usually Lasix and potassium go together, and it's just kind of a thing for you to tuck in your backpack of information so you know going into clients' homes. The meds are crucial with CHF clients. They can't stop any meds cold turkey. They usually have to be titrated off. So if they come home from seeing the doctor, you see them the next day and they say, oh yeah, my doctor took me off that and I'm just stopping it. Just know that it's not a good idea. It's usually never the case, and maybe they misunderstood. And again, Christy Post and I are always available for questions. If you run across this kind of a medical question, feel free to contact us. Everybody has our cell numbers. We text, we email, whatever, so we're happy to help answer those questions. The other thing that's important with CHF clients is that they have a low sodium and fluid restricted diet, and that's so that we're not dealing with the fluid overload. Sodium, as you know, if they eat a lot of salt, they retain fluid. My father-in-law has CHF, and when I make pumpkin seeds in the fall when I do pumpkins, and I like to salt them really good, and whenever he has those pumpkin seeds, the first year I made them, he ate them all in one sitting. Well, guess what? He was up like 5 pounds the next day. And so we determined that he probably can't eat all the pumpkin seeds all at once. So it doesn't mean that they can't have some of these things, even a salty item, but it just means that they have to limit their intake. So instead of eating them all at once, they have a few every day for a few days, and they watch their weight. Again, that's the number one way to monitor how the CHF is doing. When to call the doctor. For CHF clients, it's a little bit different. They'll know when they're not feeling well, if they have more shortness of breath, if that weight is up more than 2 to 3 pounds from the day before, if their heart rate is up, if the blood pressure is down, or their oxygen saturation is lower. That can be not necessarily due to the lung problem, but due to the heart problem, which means they're retaining fluid, and it makes it harder for the heart to pump, and it kind of all goes together. If their color is poor or they seem confused, again, you can have that oxygen level issue that's heart related, not necessarily lung related. Or anything that seems abnormal. These clients can decompensate and deteriorate very quickly because their heart pump is not fully functioning. So we have to watch them closely and understand that things can change quickly. One of the emotional responses that I've seen in clients is, again, they struggle with depression, anxiety, and sometimes well-meaning medical personnel will inadvertently feed the feeling of hopelessness and I have a situation I'm going to tell you when I talk about my case study dealing with CHF, that your heart isn't functioning very well, and so they feel like death is imminent, and that, because their heart isn't functioning, we all know we need a heart to live, and so they can inadvertently feed that, and you need to go and encourage them that they need to go by how they feel, and they need to pace each day, and every day is a new day, and people can live with CHF for a long time. These medications are wonderful, and they're very important. So I guess as far as what kinds of things we can do to relieve symptoms, it's really pretty specific. It's more of a monitoring. It's not like we can give them more medication, but we can certainly contact the doctor. If their weight goes up 3 pounds and you call the doctor, most likely they'll tell them to take another Lasix and, or come in the next day or something like that. So communication is an important piece of all this, and educating our clients on what kinds of things we can do. The case study I wanted to tell you about with CHF is a family member that was diagnosed with it, and they were told that they couldn't they loved live in Wisconsin. Fish fries on Friday nights are very big in Wisconsin. And they're, they're salty, they're fried food, not the best. However, anything in moderation is usually doable. Now, unless you add salt to everything and you make things, so salty that that they would retain so much fluid. And the doctor had scared her to death that she was going to die over the weekend and she couldn't have fish fries anymore. And so it's just an education piece that they understand they can still have their mashed potatoes and gravy, but instead of adding salt to the gravy, they try, the salt substitute, or they have a limited amount in small meals and things like that. So, we don't have to be draconian. We just have to help support their illness and the kinds of things that they need, and not and encourage them that people can live a long time with us. Now, some people don't, but some people do. And so with the right kind of medical treatment, we take the clients where they are, we help them achieve the most independence possible, and we support them. The combination of these, there's a lot of common themes, as you can tell, and a lot of the clients deal with the psychosocial type issues. They deal with depression. They deal with stress, the stress it causes their family. They deal with anxiety, shortness of breath. I don't know if, like I described, if, when you're underwater, trying to catch your breath and feeling like you have that pressure, like you can't fully breathe. It'd be like somebody giving you a big hug all the time and you can't quite get all the air in or quite get all the air out. It's stressful. It's difficult. So it's important that we give emotional support to them. And understand that it's a stress on the client and the family. So how we work with these clients is we just support them. We take them where they are, we help them achieve as much independence as possible, and we try to answer their questions and educate them. Christy Post and I are available for questions for that education piece at any time, so feel free to ask us. Does anybody have any questions?
So Cheri, is there I know you mentioned everybody has their own expected potential outcome on this. Is there anything that people can do that, are experiencing these that can extend their life, or is it pretty much once you're diagnosed with one of these, diseases, there's a finite time in, or have you had people that live, 20, 30 years beyond their diagnosis, or what does that look like?
Phil, unfortunately, it is pretty individualistic. These clients, they can live a long time. It's important that they follow their treatment and their plan of care, and that they're on the right medications. I wanted to give all of you and the caregivers some of the common medicines. So sometimes doctors are, if they go to a family practice doctor and maybe they're not as versed in CHF and they don't know about, the first line that most of these clients should be on beta blockers and ACE inhibitors, some of the medication pieces, some of the, for COPDers, I dealt with a doctor that, said, yes, I know my COPD client is on 5 liters of oxygen. And I even said, are you sure you know and you understand? And and they said yes. So at least you're able to ask the right questions. And as far as helping them, it's really symptoms and monitoring, trying to catch if they are exacerbating either of these illnesses, that you catch it early. Don't ignore the symptoms of confusion or feeling, when you're seeing these clients day after day, you get to know them pretty well. You get to know the kinds of things they talk about, how they communicate, even their speech patterns. And if you see slurring speech and not quite making it, understanding it, I ask the typical alert and oriented ×3 questions. If they know their name, even though I'll tease them, I'll say, I know you know the answers to this, but I just need to ask, So I have them tell me their full name. I have them tell me, so it's person, it's place, where are you right now? And time, what day is it today, what month, what year. And then I usually do one more, kind of like a current one, to see where their memory is and to see if obviously this is not appropriate for somebody who has dementia or Alzheimer's, but who's the president of the U.S.? Most people should know that, and if they don't, you might be dealing with a lack of oxygen or something else that's going on.
Do you find these diseases to be a little bit more challenging because we're at altitude here than, say, if we lived in Florida?
Definitely. Most people, I believe, if I remember my statistics, it takes at least 6 months for you to get the increased hemoglobin in your system to carry the oxygen, because we live at the high altitude. So particularly somebody who's coming from sea level or the Midwest and they move here and they have these diseases, all of a sudden they're feeling worse, they're more short of breath, their oxygen sats are lower. It could very well be altitude, and you need to know that too. So that's a good question.
Mm-hmm. So do we have any other questions? We're about 37 minutes in here this afternoon, and see if we have anything developing here. Looks like we are kind of getting ready to wrap here. So I want to let everybody know. So coincidentally enough,